Hello everyone. Next, we will learn about orthopedic disease in knee joint. First, we will begin to learn the anatomy of the knee. Let's first go through the bones in knee, which include medial and lateral condyle of femur, medial and lateral condyle of tibia and patella. There are two enlargements at the lower end of femur, which are called medial condyle and lateral condyle respectively. There are smooth articular surfaces in the anterior, inferior, and posterior condyle, which form a joint with patella and tibia respectively. The articular surface in the anterior side of the medial and the lateral condyle of femur are connected with each other, which is called patellar surface. The deep fossa between the posterior part of the medial and lateral condyle of the femur is called intercondyle fossa. The most prominent protrusion of the medial and lateral condyle of femur are called medial epicondyle and lateral epicondyle respectively, which are easy to touch on the body's surface. The upper end of tibia is enlarged, and there is an articular surface in the upper part of the enlargement, forming a joint with both condyles of femur. There is a small eminence protruding upward in the middle of articular surface, which is called intercondylar eminence. This eminence divides the upper end of tibia into medial condyle and the lateral condyle. There is a fibular articular surface in the posterior and inferior of the lateral condyle, which forms a joint with fibular head. As for the patella is relatively triangular with its tip down and is embedded in the quadriceps femoris tendon. And behind it is the cartilage surface, which forms a joint with the cartilage surface between the medial condyle and lateral condyle of femur. Its lower pole is rough surface. Outside the joint, the lower end of patella is connected to the tibial tubercle through the patellar tendon. Patella is the largest sesamoid bone in a human body and also an integral part of knee joint. Patella can protect the knee joint, enhance the muscle strength of quadriceps femoris, and straighten the knee joint. Secondly, we will learn the tendons and ligaments of knee joint. Knee joint is the largest and most complex joint in human body. It has the following characteristics. First, the articular capsule is wide and lax, and the thickness of each part is different. The ligament is strengthened around the capsule, and its anterior is the patellar ligament, which is the continuation of quadriceps femoris tendon from the lower margin of patella to the tibial tuberosity. And the knee tendon reflex is clinically examined by tapping this ligament. There are tibial collateral ligament and fibular collateral ligament on both sides. The collateral ligaments on both sides are tense when strengthening knees and lax when bending knees. Secondly, There are anterior cruciate ligament and posterior cruciate ligament connecting femur and tibia in the capsule, which are arranged crosswise. The anterior cruciate ligaments starts from the outer posterior part of the femoral intercondylar fossa and ends forward in the anterior part of the tibial intercondylar eminence in order to limit the forward displacement of the tibia. The posterior cruciate ligament starts at the inner front of the femoral intercondylar fossa and ends back at the posterior of the tibial intercondylar eminence to limit the posterior displacement of the tibia. If the anterior cruciate ligament is injured, the tibia can move forward passively, while the posterior cruciate ligament is injured, and the tibia can move backward passively. This phenomenon is called drawer phenomenon clinically. Thirdly, there are fibrocartilage plates between the medial and lateral condyles of femur and tibia, which are called medial meniscus and lateral meniscus respectively. The periphery of the plates is thick and the inner margin is thin, and it is half-moon shaped. The lower surface is flat and upper surface is concave. The medial meniscus is large and in the shape of C, and its margin median is closely connected with the articular capsule and tibial collateral ligament. The lateral meniscus is small and approximately in the shape of O. Meniscus deepens the glenoid fossa, thus making the joint more stable and absorbing the shock during jumping and strenuous exercise. The knee joints move mainly around the coronal axis for bending and stretching. And in the knee bending state, slight medial and lateral rotation around the vertical axis can also be done. Next, for the vascular and nerve aspects of the knee. The popliteal fossa contains important blood vessels, nerves, and lymph nodes. From shallow to deep are the tibial nerve, popliteal vein, and popliteal artery, and the common peroneal nerve located inside the biceps femoris tendon. The blood vessels are surrounded by deep lymph nodes, and flat and loose connective tissue are filled between the main structure in the popliteal fossa. The tibial nerve comes from sciatic nerve in the superior popliteal fossa, which is located in the midline of popliteal fossa, goes to the lower margin of popliteal muscle, and enters the rear part of lower leg through the medial and lateral head of gastrocnemius. The common peroneal nerve branches off from the sciatic nerve in the superior popliteal fossa, goes down the medial margin of the biceps femoris tendon, crosses the lateral head surface of gastrocnemius, reaches below the fibular head, and bypasses the fibular neck, where it is divided into superficial peroneal nerve and the deep peroneal nerve. The popliteal vein is formed by the confluence of anterior and posterior tibial veins at the inferior corner of the popliteal fossa. The popliteal artery is a continuation of femoral artery. At the depth of popliteal vein and slightly medial side, it inclines outward along the deep surface of the semimembranous muscle and descends vertically to the middle of the popliteal fossa. At the inferior margin of the popliteal muscle, it is divided into anterior tibial artery and posterior tibial artery. The upper part of the popliteal artery is close to the popliteal surface, so the fracture of the lower femur is easy to be injured. Finally, we will learn the special examination methods of knee joint, which mainly include the following.
Mark-Morris's test. The patient is in superior position. Firmly face the hip and knee joint on the affected side. Try to keep the heel touching hip. When examining the medial meniscus, the examiner holds the knee with one hand. Hold the foot with the other hand to keep the lower leg in full abduction, lateral rotation position, and straighten the knees. When examining lateral meniscus, keep the lower leg in full abduction and lateral rotation position, and straighten the knee during retention. A bunch can be heard. If the patient has heard the bunch sound and feel pain on the medial side of the knee, the test is positive.
Apply test. The patient is in prone position during operation. Keep knee flexion by 90 degrees. While holding the heel with both hands and exerting pressure along the longitudinal axis of the neck, performing the abduction and external rotation or adduction and internal rotation of the neck. If there is pain or clicking, it is positive. Indicate lateral or medial meniscus injury. Pain caused by lifting the lower leg to do abduction and external rotation or adduction and internal rotation. Indicate injury of lateral collateral ligament or medial collateral ligament. Jaw test. During operation, the patient is in sitting or supine position. Keep the knee flexion by 90 degrees. The examiner presses the patient's ankle and foot with one elbow. Hold the upper part of the lower leg with both hands to push or pull. If the lower leg can be obviously pulled forward by about 1 centimeter, that is the front jaw test is positive. Indicate that there is anterior cruciate ligament injury if it can be pushed back about 1 centimeter. That is the back jaw test is positive. It is the injury of the posterior cruciate ligament if both the front and back can be pushed and pulled for 1 centimeter. The front and back jaw test is positive. Indicate that there is anterior and posterior cruciate ligament injury. Lateral extrusion test, also known as knee joint separation test, lateral movement test, and Buckner sign. The patient stretched his knee and fixed the thighs. The examiner holds the ankle with one hand, then holds the knee with the other hand. Perform lateral movements to examine the medial or lateral collateral ligament. If there is any injury, it may cause pain or abnormal movement. Floating partner test during operation. The patient is instructed to be in the supine position. with the lower extremity extended. Keep his quadriceps firmly be in a relaxed state. The examiner presses on the suprapalmar bursa with one hand. Squeeze downwards to limit the effusion to the joint cavity. Then fix the inner or outer edge of the panel with the thumb and the middle finger of the other hand. Press the panel with the index finger. If you feel a floating sensation with the panel, there is a feeling of the subsidence under heavy pressure, and floating when the fingers are loosened. That means the panel floating test is positive, indicates that there is effusion or hematose in the articular cavity.
Well, class is over. Please review what we learned today after class. Thank you.